Now next I invite Dr. Bhumika.
Good morning to one and all. I shall be speaking on the outcomes of three-piece rigid SFIOL implantation in subjects with deficient posterior capsule following complications in manual small incision cataract surgery. So we have a lot of choice of IOL placement, and SFIOLs are placed point closest to the nodal point of the eye and at a greater distance from the cornea. So our study is the only retrospective study determining the visual outcomes and post-operative complications of combined pars plana vitrectomy with SFIOL in complications of manual small incision cataract surgery in a large cohort of patients. The objective of the study is to evaluate the surgical visual outcomes of three-piece rigid SFIOL in subjects with deficient posterior capsule in complications of SICS. This is a retrospective 4-year cohort study with participants of 174 eyes that underwent combined PPV with SFIOL as secondary surgery with at least a follow-up of 6 months. The inclusive criteria included the primary surgery had to be SICS, there had to be inadequate posterior capsular support, there had to be had a nucleus drop or a IOL drop or posterior subluxated IOL which needed pars plana vitrectomy, and the patient follow-up had to be 6 months. The exclusive criteria included traumatic aphakia, patients with follow-up of less than 6 months, nucleus or IOL drop due to phacoemulsification, and any associated ocular comorbidities like vitreous hemorrhage, glaucoma, retinal detachment, corneal or scleral injury. The primary outcome measures were the post-operative best-corrected visual acuity, post-operative complications, and the secondary outcomes were post-operative IOP, post-operative refractive status, and the IOL orientation. Coming to the surgical technique, our technique was a modified Agarwal's technique that was completely like Agarwal's technique without a glue. SFIOL and PPV was done in a 25-gauge constellation vitrectomy system, and fragmentome was used for nucleus drops, and a new 3-piece IOL was implanted in every case of IOL drop. Coming to the procedure, we made a partial thickness scleral flap that 2 mm from the limbus at 0 and 180 degree. The leading haptic tip was held with microforceps and exteriorized. Similarly, the trailing haptic was exteriorized, and the tips of haptics were tucked in the scleral tunnel made by a 26-gauge needle and were sutured. Coming to the follow-up, the patients followed up at 7 days and 1 month, and then monthly thereafter. The follow-up time had to be at least 6 months, and the spectral domain OCT was done in all cases. For IOL centration, Purkinje images of the cornea and IOL was captured intraoperatively. IOL tilt, finding the IOL tilt, the pupil is completely dilated, and separation between the posterior surface of the iris and the nasal and temporal edges of the optic was calculated. The degree of orientation and IOL decentration was calculated by the length between the nasal and temporal border of the optic and their respective limbus. This is a picture of IOL centration after 6 months. The statistical analysis was done in SPSS 26, and the pre and post-operative best-corrected visual acuity was calculated in logMAR. Coming to the results, the mean post-operative follow-up time was 14 months, and the mean presenting age was 58 years, and there was 62.6% male and 37% female. The most common surgical indication was surgical aphakia, followed by posterior dislocation of IOL, subluxation of IOL, and nucleus drop. Coming to surgical outcome, the pre-operative best-corrected visual acuity was 20/400, and the post-operative was 20/40 or better. The mean pre- and post-operative IOP was 17 and 15 respectively. The refractive status was calculated in spherical equivalent, and pre-operatively it was 4.1 plus minus 6.2 diopter sphere, and post-operatively minus 0.4 plus minus 0.97. Coming to surgical complication, the most common surgical complication was corneal edema in 9% of patients, and followed by secondary glaucoma in 7% of patients. There was 1.1% of patients who needed IOL refixation because of IOL decentration or tilt. Our paper was published in a PubMed in Helion. Coming to the discussion, there were 174 subjects, 110, 63.2% post-operative best-corrected visual acuity was 20/40 or better. There was satisfactory refractive outcome that was closer to the targeted refraction. Post-operative complications were comparative to most of the previous studies. Our study indicates similar ranges of post-operative complication as previous, and there were larger number of eyes and longer follow-up duration. IOL dislocation and suture breakdown may be present within 6 months. Most investigations only reported between 2 and 5 years after surgery. Rate of not related complication varies between studies. Our findings suggest that even existing scleral flaps do not entirely prevent knot erosion over the long term. The limitations of the study include it is a retrospective study, so chances of bias are always there. There are no control group. There is no comparison, and we have done it in a single technique of pars plana vitrectomy with SFIOL with a flap, and it needs further comparison with PPV plus SFIOL for post-operative complications of phacoemulsification. To conclude, this technique of pars plana vitrectomy with SFIOL, that is glueless flap and suture, is a safe technique of aphakia rehabilitation in deficient posterior capsule and provided good visual outcomes, well tolerated in long term in a large cohort of patients following complications of manual small incision cataract surgery. Thank you.